In Kenya, where you're born is not just an address, it is a sentence. This is not a story about poverty. It is not a story about disease. It is a story about choices. The choices made by governments, by county officials, by a parliament that has not debated this crisis in years. The choices that determine whether a child born today in Migori lives to see their 5th birthday. The 2022 Kenya Demographic and Health Survey, the most comprehensive national health data Kenya produces, tells us something that should have stopped every newspaper in this country. In Marsabit County, 15 children die for every 1,000 born live before their 5th birthday. In Migori County, 73 do. The national average is 41, but that national average is doing what averages always do. It is hiding the gap. It is flattening a crisis into a statistic. These are not numbers from a war zone. There is no famine here, no armed conflict, no natural disaster. This is Kenya in 2024, a country with a functioning government, 47 county health departments, and billions of shillings in annual health budgets. So the question these films ask is simple. If the money exists, if the drug exists, if the knowledge exists, why are children in Western Kenya still dying at rates that match the worst conflicts zones on earth? Look at the table carefully. The 5 best performing counties in Kenya have under 5 mortality rates between 15 and 24. They have HIV prevalence rates below 6%. Their vaccination coverage sits above 78%. Now look at the bottom: Migori, Homa Bay, Siaya, Kisii, Nyamira. Mortality rates between 63 and 73. HIV prevalence in Homa Bay, 25.7%, nearly 7 times the national average. Vaccination coverage as low as 57%. And notice where these counties are. 11 of the 12 worst performing counties in Kenya are concentrated in Nyanza and Western Kenya. The geography of death in this country is not random. This disparity is not a coincidence. It is systematic failure. And we need to understand exactly what that system is failing to do and why. 3 forces converge in Nyanza and Western Kenya in a way they do nowhere else in the country. The first is malaria. The World Health Organization classifies the shores of Lake Victoria as permanent malaria transmission zone. Low altitude warm water, year-round mosquito breeding. In Siaya County, malaria accounts for 33% of all deaths in children under 5. Not 33% of disease cases, 3% of deaths, 33% of deaths. The second is HIV. Homa Bay County has an HIV prevalence of 25.7%, 1 in 4 adults. Without antiretroviral treatment, 1 in 3 HIV positive infants die within their first year of life. Homa Bay, Siaya, Kisumu, and Migori together contribute over 40% of Kenya's new HIV infections in children annually. The third is what this diagram calls weak facilities, the clinical term for dispensaries without drugs, wards without nurses, cold chains without power, and a health worker who is 3 years behind on salary. When these three forces meet in the same community, in the same household, in the same infant, you get the Nyanza trap, where the disease burden is at its absolute worst and the infrastructure to address it is at its absolute weakest. That intersection is why children are dying. The last mile breakdown. Kenya has the vaccines. Let me be precise about that. The Kenya Expanded Program on Immunization, KP, has been running since 1980. The BCG vaccine, the polio vaccine, the measles vaccine, they are procured. They arrive at national warehouse. They're transferred to regional cold storage in Kisumu, and then something breaks. A cold chain in Kisumu does nothing for a child born in a village 30 kilometers from the nearest dispensary. A vaccine that requires 2 trips to a clinic does nothing for a mother who cannot afford the transport or cannot leave her older children or is 3 months postpartum and still bleeding from a complicated delivery at home. Only 57% of children in Migori are fully vaccinated. The national average is 75%. The SDG target is 90%. This is not a supply problem. It is a last mile problem. And the last mile has never been adequately funded, staffed, or held accountable. The currency of choices. Here is a budget question, the one that nobody in the health ministry wants to answer directly. In 2023 to 2024 financial year, Kenya allocated 4.3% of its national budget to health. The Abuja Declaration, a commitment Kenya signed in 2001, 23 years ago, requires a minimum of 15%. Kenya has never met that commitment, not once. Meanwhile, debt service, the repayment of loans to the IMF, the World Bank, and commercial creditors consumed over 60% of tax revenue in the same year. Every shilling collected from a Kenyan taxpayer, 60 cents goes to a foreign creditor before a single nurse is paid, before a single bed net is procured, before a single child in Migori receives a vaccine. Kenya is not poor to fund healthcare. That argument is no longer available to this government. Kenya is a country that has made a choice. It has chosen debt service over dispensary. It has chosen IMF compliance over infant survival. And the children of Nyanza are paying for that choice. More money does not equal fewer dead children. But let us not let county governments escape, because devolution means that this is also their failure. In 2013, Kenya devolved healthcare to the county level. The intention was sound: bring decision-making closer to the communities that need it. A decade later, the data tells a more complicated story. This scatterplot map county health spending against child survival outcomes. If money were the only variable, you'll see a clean line. More money, better outcomes. You do not see that. Look at the counties in the red circle. Average budgets, devastating outcomes. These are accountability black hole counties. Places where health funds are allocated but children still die at alarming rates. The Kenya Health Sector Integrity Monitor has documented procurement irregularities, supply chain collapse, and stolen funds in several of these counties. Supply chain collapse and stolen funds kill just as effectively as the disease. Now look at the blue circle. That is Makueni. Average budget, exceptional outcomes. Under Governor Mutula Kilonzo Jr., Makueni introduced a county-wide social health insurance scheme. paid community health workers on time, and tracked every dispensary drug supply. The results show in their mortality numbers. The tools work when the will is there. The political economy of neglect. Here's is a fact this film will state plainly because no official health report will. The communities with the highest child mortality rates in Kenya are, with near perfect overlap, the communities that have been in political opposition to the national government for the past 2 decades. Nyanza, parts of Western Kenya, the Luo Heartland, the Lake Victoria Basin. We're not saying that the government deliberately withholds healthcare from opposition communities. We're saying the data shows that a pattern. Infrastructure investment, facility upgrades, health worker hiring, drug procurement budgets, these flow more easily when a country's political leadership is aligned with the executive. That is not a conspiracy theory. That is how political economies work. The silence is also a statement. The National Assembly Health Committee has not convened a specific debate on Nyanza child mortality since 2019. 7 years, over 120,000 estimated child deaths in that period, and a parliamentary silence. Correlation is not causation, but the pattern demands explanation, and no one in authority is offering one. The Lwala Divergence. Now, we turn to what works, and we begin in the same county where the crisis is worst. In Rongo sub-county, one of the most vulnerable areas of Migori County, a community organization has spent 17 years proving the pessimist wrong. The Lwala Community Alliance was founded in 2007 by 2 brothers who grew up in this community. They watched family members die from preventable diseases. They decided to do something about it. They built a hospital. They trained and paid community health workers. They enrolled every pregnant woman in their catchment area. They tracked every newborn. Look at what happened. Before the intervention, 2007, under 5 mortality in their area was 104.8 per thousand. By 2017, it was 29.5, near the SDG target. In the same county where the overall rate today is 73. They did not discover a new drug. They did not invent new technology. They applied known tools consistently at community level with accountability to the people they served. That red horizontal line you see, 73, is what the county government is delivering. The falling line is what community accountability delivers. The tools exist, the variable is political will. Where does Kenya stand? Africa in context. Before we look at what Kenya must do, we need to understand where Kenya actually stands, not just against itself, but against the continent. Kenya national under 5 mortality rate of 41 is better than the sub-Saharan African average of 72. But by that measure, Kenya is performing above the regional norm. But look at that chart again. Migori County, 73, sits at the level of Chad and Nigeria. The worst performing county in Kenya has mortality rates that match the most troubled health system in West and Central Africa. That is the story the national average conceals. Kenya is not failing Africa. Kenya is failing its own Western communities. The crisis is not national. It is hyperlocal, hyper-concentrated, and hyper-preventable. And critically, the counties performing better than Kenya are not richer. Many of them are poorer. So the question is not about resources. It is about those countries decided to do with the resources they had. Africa proof of concept. 3 African countries have done something that the Kenya government has argued is too difficult, too expensive, or too complex to achieve. Rwanda started this century with an under 5 mortality rate of 182 per 1,000, nearly double Kenya's at the time. Today it is 36, an 80% decline in 2 decades. How? 45,000 community health workers, one assigned to every village in the country. Universal community health insurance that covers over 90% of the population, including the rural poor. Funding tied directly to facility performance, and a government that enforces its own targets. Ethiopia deployed 35,000 health extension workers into the countryside. Not nurses with degrees, trained community workers who visit homes, track children, administer vaccines, and report to a functioning chain of accountability. Under 5 mortality fell 71%. Senegal built a centralized primary health care network, introduced community case management of malaria and pneumonia at village level, and committed to spending above 8% of its budget on health. 63% declined. None of these countries invented a new medical breakthrough. They applied the same tools that exist in Kenya: bed nets, vaccines, community workers, insurance schemes with the one ingredient that is consistently missing in Nyanza: sustained, accountable government commitment. The mirror, what Kenya could look like. This chart is perhaps the most important image in this entire documentary. Let me explain why. In the year 2000, Rwanda under 5 mortality rate was 182. Kenya's was 115. Rwanda was in a worse position by any measure. It was still rebuilding from a genocide. Its health infrastructure was in ruins, and its economy was smaller than Kenya's by a significant margin. By 2015, the 2 lines on this chart had nearly converged. Rwanda had fallen faster, Kenya had progressed, but inconsistently. After 2015, the lines diverged again, this time in opposite directions. Rwanda continued declining, Kenya's rate of improvement slowed. Today, Rwanda is at 36, Kenya is at 41 nationally and 73 in Migori. 3 lessons explain the difference. First, community health workers. Rwanda assigns 1 to every village, pays them, equips them, and holds them accountable. Kenya's community health workers are underpaid, under-equipped, and inconsistently deployed. That is not a medical problem. That is a governance problem. Second, universal health insurance. Rwanda's community-based scheme covers over 90% of its population. Kenya's social health insurance fund is being contested in the courts and remains incomplete in rollout. Meanwhile, families in Migori are paying out of pocket for drugs that a functioning system should provide for free. Third, accountability at facility level. Rwanda ties health funding to performance data. If facility vaccination rate drops, it faces consequences. Kenya funds facility regardless of outcomes. No measurement, no pressure, no change. Rwanda started worse. Rwanda is now better. The gap between them is not resources. It is the will to govern. The malaria vaccine turning point. There is one development in the last 2 years that genuinely changes the equation. Kenya is at the front of the line for the world's first malaria vaccine. R21 Matrix M vaccine has demonstrated 70 to 80% efficacy against malaria in young children, for a region where malaria causes 1 in 3 deaths in children under 5. That efficacy, if delivered at scale, represents the most significant public health intervention in a generation. But here is the and it has a serious catch. A vaccine program only works if it reaches every child. In a region where 43% of children do not complete their basic polio vaccination schedule, a vaccine program that has been running for 50 years, there is no guarantee the malaria vaccine will do better. Not without a fully funded, fully accountable last mile delivery strategy. Not without the community health workers who knock on doors, track children, and follow up when families miss appointments. Medical miracles cannot survive broken logistics. The policy demand scorecard. This is not an NGO appeal for donations. This is a demand for the people responsible for these deaths to answer for them. To the National Treasury, the Abuja Declaration requires 15% of the national budget for health. You are currently at 4 to 6%, while you service loans to the IMF at over 60% of tax revenue. Children in Migori die of malaria. That is not a development challenge. That is a political choice. Change it. To the county governments of Migori and Homa Bay, Health Devolution gave you the mandate and funding. Explain to your constituents why vaccination coverage in your counties is the lowest in Kenya. Explain where the health budget went. Explain why community health workers are waiting months for wages. Explain. To the National Assembly Health Committee, to the last parliamentary debates, specifically on under 5 mortality in Nyanza was in 2019. 7 years. You have the constitutional mandate to oversee the Ministry of Health. Use it. The amber dots on community health worker compensation is the only partial concession to progress. Some counties have begun addressing delayed wages. It is not enough and it is not consistent, but it is movement. Everything else on this scorecard is red. 120,000 between 2022 and 2026. An estimated 120,000 children died before their 5th birthday in the 11th highest mortality counties of Kenya. Most of these deaths were preventable. The drugs existed, the vaccine existed. The knowledge existed, the community health worker existed, underpaid, under-equipped, but they existed. And for 120,000 children, none of it reached them in time. None of the responsible officials have been held to account. Not one county health director, not one cabinet secretary, not one parliamentarian who sat on the health committee and said nothing while the numbers climbed. This is a story Kenya has not told itself. The story that should be on the forefront page of every newspaper, the lead item on every evening bulletin, the first question at every budget debate in parliament. Every number in this documentary was once a child, born somewhere along the shores of Lake Victoria, or in the highlands of Kisii, or in a village on the edge of the rift. A child who was held and named and died of a disease that cost less to cure than the interest on a single government bond. Where the early edition, the story is not over, it is just beginning to be told.